All right, hello everyone. It's 12 o'clock. We'll go ahead and get started. Thank you so much for joining us today. This is our seventh session of the third series of the Pediatric Mental Health Tele-Echo. I'm Jody West, and I'm the coordinator for the ECHO and the program manager for PPCL. I want to go over a few housekeeping items. If you can go ahead and enter your name, title, organization, and email address in the chat. That way we can keep attendance. This is going to be our agenda today. We'll do our best to adhere to this schedule. After I finish a few announcements, our facilitator, Dr. Olivier, will lead us in introductions of the hub team, and I'll say a little bit about PPCL. Ashley is going to then present, Ashley Hutchins is going to present our didactic, and then we're going to move to our case presentation by Dr. Merritt. Once the case presentation is given, then we'll open the floor for clarifying questions and recommendations that we will then send to the team, to everybody that participates. So I want to go ahead and introduce myself. I'm Jody West. Like I said, I'm the coordinator for the ECHO. I am the program manager for PPCL, which is the provider-to-provider consultation line. We're a no-cost provider-to-provider telephone consultation and education program, and we focus on pediatric and perinatal mental health and helping non-mental health providers provide care to meet their patients' needs. So if you scan that QR code, it'll bring you to our website, and you could always give us a call and get more information. The ECHO is part of our education and training that we provide through PPCL. Dr. Olivier, would you like to introduce yourself, please?
Hey, good afternoon, everybody. I'm Dr. Olivier. I'm a child and adolescent psychiatrist over here in Lafayette, Louisiana, in private practice. I'm the facilitator for these sessions, so I will be managing the clock and trying to keep us on our schedule as best as I can. I'm going to ask the rest of the hub team to introduce themselves, starting with Dr. Queen.
All right. Hi, everybody. I'm Dr. Katie Queen. I'm a general pediatrician for Our Lady of the Lake Children's Health, and I'm part of the hub team. I think this is my second cohort. I've been part of it, and I just really enjoy both the teaching aspect and the learning aspect. I'm also practicing obesity medicine, which, as you can guess, has a lot of mental health overlap. So I'm happy to be here.
Thanks, Dr. Queen. How about Ashley Hutchins?
Hi, I'm Ashley Hutchins. I'm a psychiatric nurse practitioner in Lafayette, Louisiana, at Blue Mental Wellness.
Thanks, Ashley. Ashley's also presenting our didactic today. And Lena, you want to introduce yourself?
Sure. Hi, everybody. My name is Lena Reggette. I'm an LCSW, also part of the hub team, and I am one of the mental health consultants for PPCL.
Thank you, Lena. And y'all already met Jody, our program coordinator. So we are going to go right into our didactic presentation from Ashley Hutchins this morning. So go ahead and take it away.
Okay, so like I mentioned, I'm Ashley Hutchins. I'm a psychiatric nurse practitioner here in Lafayette, Louisiana at Blue Mental Wellness, and I will be doing a didactic on mood disorders and risk assessment in adolescents today. Next slide. So the objectives, we're going to look at the epidemiology of mood disorders in adolescents, highlight characteristics of mood disorders that are more commonly seen in the adolescent population. And then our main focus is going to be really on identifying risk assessment tools and therapeutic communication techniques, in addition to discussing clinical decision-making and evidence-based treatment modalities for adolescents who are at risk for suicide and non-suicidal self-harming behaviors. I do have more slides than I have time, so some of these things will be skipped over, but you'll be getting all this information emailed to you at the end as well. And go ahead to the next slide. So just some statistics. Approximately 1 in 7 or 14% of children between the ages of 10 to 19 will experience a mood disorder. The leading causes of illness in this population include depression, anxiety, and behavioral disorders. And failure to address mood disorders in adolescents can lead to ongoing mental and physical health complications into adulthood. Also, suicide is the second leading cause of death among youth ages 10 to 19 years old. So it's very important that we address these concerns. Next slide. So some common mood disorders we may see in adolescents. I'm not going to go too in depth, but you've got major depression, persistent depressive disorder, bipolar disorder, you can have disruptive mood dysregulation disorder, premenstrual dysmorphic disorder, mood disorder due to a general medical condition, and then substance-induced mood disorder. What these all have in common is that they do put children at risk for suicidal ideation, behavior, and self-harm. Next slide. So adolescence is a particularly challenging time. They are going through physical and emotional changes secondary to puberty. There's also increased stress related to peer pressure, that psychosocial developmental stage of identity versus role confusion, the media influence, stigma, bullying, and then home environments and socioeconomic statuses also pose challenges for adolescents. Next slide. So the presentation of mood disorders in adolescence, the symptoms can vary according to age, but they include intense emotional changes that last longer than usual and or occur more frequently. This can include sadness, anger, elevation. We may see increased interpersonal conflict with family, peers, teachers. You may hear teens expressing feelings like things aren't fair, feel like other people do not care. They may feel like a disappointment themselves. You'll often see lower frustration tolerance, increased argumentative behavior. They may even start bullying others themselves. We also see decreased motivation, decreased interest or pleasure in activities, changes in sleep pattern and appetite. Next slide. And somatic complaints are pretty prevalent as well. They'll often complain of just not feeling good. They may have headache, fatigue, stomach aches, decreased energy. You may see academic difficulties arise. If bipolar disorder is underlying, they will have increased energy with racing thoughts, rapid speech at times. We may see an increase in oppositional behavior and risk-taking behavior, like running away, substance use, promiscuity, symptoms with low self-esteem, they may be isolative, and then ultimately we could also see suicidal ideation, gestures, and self-harm behavior. Next slide. So therapeutic communications. You always want to interview adolescents separate from their parents. Of course, you want the parents' input, but you want to interview the adolescent one-on-one. They do have limited insight and often may feel embarrassed or reluctant to discuss sensitive topics like depression, suicidality, and self-harm. So approaches that you can take would include kind of like normalizing these questions. I'll say a lot, everybody I know feels sad or bad about themselves sometimes. Do you ever feel that way? And if you do, what is it that makes you feel sad? Would you say that you were sad most of the time, or are you usually happy, or do you kind of stay in between for the most part? I do find Likert scales to be helpful for adolescents who have difficulty really verbalizing and articulating their emotions. So a lot of times I'll say, on a scale of 1 to 10, how sad or annoyed have you been lately? And that helps them kind of quantify it a little bit better. Next slide. Okay, so risk assessment. The American Academy of Pediatrics recommends universal depression screening for children ages 12 and older, regardless of the reason for the medical visit. Children ages 8 to 11 should be screened for depression if they present with behavioral concerns, or if they have a history of suicidal ideation, risk factors for suicide, and or if a parent's expressing concern. And then screening typically is not indicated for children under the age of 8 unless there is concerning behavior or warning signs present. If they're displaying some impulsive aggression, or if they're acting out any play like they're choking themselves or shooting themselves, if they're talking about wanting to die, or if you see any sort of self-harming behavior, head banging, anything like that. Next slide. So screening tools that we can use to assess depression, we're all familiar with the PHQ-9. There is an adolescent version, the PHQ-9A. So in addition to looking at the symptoms and measuring how often they're occurring, it goes a little more in depth. It adds at the end of this questionnaire, it asks, in the past year, have you felt depressed or sad most days, even if you felt okay sometimes? The answer is yes or no. It also asks if you are experiencing any of the problems on this form, how difficult have these problems made it for you to do your work, take care of things at home, or get along with other people? Extremely difficult, very difficult, somewhat difficult, or not difficult at all. And then it asks, has there been a time in the past month when you have had serious thoughts about ending your life? Yes or no. And have you ever in your whole life tried to kill yourself or made a suicide attempt? Yes or no. A lot of times adolescents can be vague. So I find that, asking these more specific questions can elicit more of a response than just the traditional questions on the PHQ-9. Next slide. However, research has shown that screening for depression alone is insufficient. For instance, that PHQ-9A missed an estimated 36% of pediatric patients who were positively at risk for suicide. Therefore, it is recommended that suicide screening tools are used in addition to depression screening tools. Some examples include the Ask Suicide Screening Questions form, the Suicide Behavior Questionnaire revised form, and then there is a combined PHQ-9A and ASQ tool that you can use. Next slide. So this is from the National Institute of Mental Health. It is the ASQ suicide screening tool. And you ask the patient, in the past few weeks, have you wished you were dead? Yes or no? In the past few weeks, have you felt that you or your family would be better off if you were dead? Yes or no? In the past week, have you been having thoughts of killing yourself? Yes or no? And have you ever tried to kill yourself? Yes or no? And if yes, how and when? If the patient answers yes to any of those first 4 questions, you want to ask the following acuity question of, are you having thoughts of killing yourself right now? Yes or no? And if they are, you want them to describe what their thoughts are. Next slide. So scoring this questionnaire, if the patient answers no to those first 4 questions, screening is complete. But if they answer yes to any of those first 4 questions or refuse to answer, it is considered a positive screen. So you want to go ahead and ask that 5th question, are you having thoughts right now of hurting yourself? And if the answer is yes, that is considered an acute positive screen with imminent risk identified. So that patient needs a stat safety evaluation, mental health evaluation, and then those are some guidelines if a nurse administers it. You don't want them to leave until we can determine their safety and keep them in sight, make sure they don't have access to anything they can hurt themselves with. If they answer no to that question, they're not actively having any thoughts of self-harm. It's considered non-acute positive screen, which means there's a potential risk. So you do want to do a brief suicide safety assessment and determine if a full mental health evaluation is necessary. The National Institute of Mental Health does recommend that we provide these resources to all patients regardless of their score. And that's the information to the 24/7 National Suicide Prevention Lifeline, 988. And then there's also the 24/7 crisis text line where they can text home to that number. Next slide. So if we have somebody that is saying that they are suicidal at risk for harm, we want to consider the risk factors involved. Of course, your rapport with the patient. Is this the first time you've seen them? How well do you know them? Looking at their history. Do they have an attempt in the past? Have they had an ongoing history of depression, mental illness, any sort of adverse childhood experiences, legal problems, impulsive, aggressive behavior, if there's any bullying going on, if there's concomitant substance use or any recent loss. Those are all risk factors to consider. Next slide. And then you want to see if there's a family history of suicide, if they're isolating themselves socially, do they have access to lethal means? Is their community one, there's violence where they live, and if they're victims of discrimination, these all put them at higher risk as well. Next slide. Just some clinical considerations to keep in mind. The suicide rate for Caucasian adolescent males is twice as high as the rate for African American adolescent males. And while adolescent males have a higher rate of suicide completion, adolescent females are actually at higher risk for suicide attempts. And then studies have shown that LGBTQIA adolescents have higher rates of suicidal ideation and attempts compared to their heterosexual peers. Next slide. You also want to look at protective factors. Do they have insight into positive coping skills? Do they have family support, peer support? Are they able to identify reasons for living, family, friends, pets? Is there any community involvement? Are they involved in sports, church, etc.? Do they have any cultural or religious beliefs against suicide? And what is their access to healthcare? Are they already in with a counselor? Do they have resources available to them? Next slide. So evidence-based treatment, psychotherapy is first line. Evidence has shown that CBT, DBT, family therapy have all been helpful in treating mood disorders and suicidality in adolescents. If they have unipolar depression, SSRIs are first line treatment. You've got fluoxetine and escitalopram that are FDA approved for children. You also have others that are off label that can be used. And if we suspect that there is bipolar disorder underlying everything, the antipsychotic medication and mood stabilizers that have been FDA approved include risperidone, aripiprazole, olanzapine, quetiapine, and lithium. But That being said, these things are all shown to work. However, they don't work overnight. They take weeks, and it takes time. So we need to come up with a plan for the here and now while those are able to take effect. Next slide. So that's where a safety plan comes in. You want to clarify, is it just ideation? Is it passive? Do they have intent? Is there a plan? And do they have a history of attempts in the past? You're going to determine that level of risk based off of the screening tools, the history, looking at their family support, access to healthcare, and evaluating those risk factors and protective factors that are present. You want to develop a safety plan with the child and the caregiver. It's a tool that's used to help clients and their parents identify resources and coping skills for ongoing suicidal ideation. And it includes elements such as family involvement, removing access to lethal means, such as like securing medications, knives, guns, and education to identify triggers and warning signs, in addition to providing them resources for support. Next slide. So this is an example of a safety plan. So the strategy, you want to know warning signs and precipitants, and it helps to kind of just have this laid out for them, because in the moment when they're caught up, it's easy to kind of forget what we're supposed to do. So if they have this, they can refer to it, parents and children alike. And knowing those warning signs and precipitants are important. You want to try to avoid situations that can trigger that suicidal ideation and behavior. For example, it may be a good idea to try to establish a truce, a temporary truce with parents about issues that lead to substantial discord. If they're just not seeing eye to eye on something, let's try not to engage in those arguments for the time being until we're in a different place. And they will need to anticipate the need to cope with stressors and problematic situations, for instance, being teased or feeling down. Then you want to secure and remove lethal agents. So have the parents complete an inventory of any weapons, firearms, poisons, medications, sharps, and assess the access that their child may have to those agents. And you want to talk through and agree to a specific plan to restrict that access, either by removing them altogether or securing access to lethal means. You want to implement individual coping skills, so you can review those reasons for living, identify distraction techniques, singing with loud music, walking outside with a friend, implement techniques that could kind of help with distress tolerance, like calming self-talk or visualization, relaxation, and then exercise are also things they can do on their own. And then you want to talk about interpersonal coping. You want to help them identify friends who can be contacted to help distract or lift their mood. But note, it is important, same age peers should only be sought for distraction and social interaction only, not to discuss suicidal or self-harm thoughts or urges. And with that being said, they need to identify a trusted adult that they can approach when they're having those suicidal thoughts or urges, whether it be their parent, youth pastor, aunt, uncle, whoever, but identify somebody that they feel safe talking to. And then give them the resources for professionals that can help. Hopefully we have a counselor lined up, give them that information, crisis line information, and 911 if they become acutely suicidal. Next slide. Okay, so the safety plan is great, but the reality is they may need a higher level of care in the future. So you do want to discuss with the client and the parent what would precipitate an emergency circumstance, when they would need to call 911. Also give them that information to the 988 suicide hotline, and you can provide them with information and community resources. I've actually typed up a little Word document with some local resources that's going to be emailed to you as well. Here in the Lafayette area, we have the Extra Mile Youth Mobile Crisis Response. What they do is they deliver services in home that can offer support and education at the onset of a crisis. And that crisis can be defined by the child themselves, by their parents, teacher, caregiver, school. And whenever you contact them, they have a 24/7 mobile response unit. They'll respond within 1 hour in the Lafayette area and within 2 hours of surrounding parishes. They offer 72 hours of stabilization and 14 days of ongoing support and education. Another resource that can be used is the Ness Center Mobile Crisis Response. That's for St. Tammany and surrounding parishes there, and they offer a similar level of care that the Extra Mile does. And it's not included on here, but I actually came across Beacon Connections is another statewide program that can offer similar services to adolescents for youth suicide prevention as well. They may need to be referred to inpatient or IOP settings if they are at a higher risk for suicide. So if they have history of attempts, impulsivity, if there's a lot of family discord, And if they're not willing to comply with treatment recommendations at that point in time, I would say it's not worth the risk of trying to keep it outpatient. Go ahead and refer inpatient and IOP to ensure safety for those individuals. Next slide. Okay, we also have non-suicidal self-harm. So you may have a child that is intentionally causing destruction of their body without an intent to die. This can include cutting, burning, scratching, biting, you name it. An estimated 25 to 30% of adolescents will engage in self-injurious behavior at least once. It is commonly seen in clients with anxiety, depression, PTSD, eating disorders, and personality disorders. And studies have shown that adolescents who engage in non-suicidal self-harming behaviors are 3 to 7 times more likely to have a suicide attempt in their lifetime. Next slide. So if you have a client with non-suicidal self-harm, you want to perform a skin check in your office. Common areas include the wrists, arms, and thighs. Obtain a history regarding the frequency and duration, methods used to inflict self-harm. Are they using erasers, scratching with their own nails, using a razor blade? Treatment is indicated for multiple episodes of self-injurious behavior, and also if self-harm is being used to cope with distress, and or if the behavior required medical intervention. For instance, they need sutures because they cut themselves so deep. When we're determining the level of care for adolescents who are engaging in this non-suicidal self-injurious behavior, it is important to ensure safety, but we want to try to maintain the highest level of functioning in school, social, and family domains as well. Next slide. So outpatient psychotherapy and medication management is appropriate for adolescents who are not at like a moderate or high risk for suicide, but inpatient hospitalization may be required for adolescents who are causing severe bodily harm to themselves, or if they cannot be adequately monitored at home, and or if they're presenting with symptoms of agitation, aggression, or psychosis, which poses a higher safety risk. Next slide. Some parent education for parents of children that are engaging in this self-harming behaviors. You want to educate them that many children who engage in this behavior are not likely to abruptly stop the behavior. Recovery is definitely a process with this. You want to teach them how to look out for warning signs, just if they see any unexplained cuts, marks on the body, if they notice that their child's covering themselves with sweatshirts, even in hot weather, if they're wearing excessive amount of bracelets to cover their wrist, avoiding activities like swimming, or if the parents are noticing bloody tissues in the trash bins, those can all be warning signs that the child's self-harming. And a strategy to try to mitigate this and stay on top of it, you can implement random skin checks. So an example of that would be like, say you have a jar and you write the numbers 1 through 5 on a piece of paper, put it in the jar and keep it on the counter. Every day, the child has to pick a number. And let's say number 3 means skin check day. The child is aware that this is the agreement. Every time that child picks number 3, you have to do a head to toe skin check to see if there's any new injuries. Also, performing room checks and securing sharps is another way to mitigate this risk. You can even have a system where, they have to check out the razor to go shave, bring it back to you immediately after they're done. Next slide. And then parental controls, surveillance, and limitation of social media use. There's all sorts of stuff on TikTok, unfortunately. So trying to get a grip on that, being aware of what your child's watching. It's also helpful to have the child keep a journal or a log of thoughts, behavior, urges, triggers, consequences for their actions. And also it's important for them to keep track of whenever they're able to successfully implement coping skills so that they can track their progress over time. A lot of my clients actually use an app to kind of track their progress, and it's called Calm Harm. It's a free app, and it actually has tools that they can use to help resist those urges for self-harm when they have them and track their progress as time progresses. And then Self-Injury Outreach and Support is a website that provides education and resources for parents of children who self-harm. Very useful. I included that website there. And yeah, that concludes my presentation. Thank you, guys.
Awesome. Thank you, Ashley. For anyone who has preteens and teens out there, just know that wearing sweatshirts in 100-degree weather is very trendy right now. Does not make. All right. Well, thank you guys for all your participation and recommendations and feedback. Thank you, Ashley Hutchins, for presenting the didactic. And thank you, Dr. Morak, for presenting our case. That was a good one. But I don't think we've had a case with eating disorders so far. So, good topic. All right. Jody, you want to wrap it up?
Yeah, we're gonna go ahead. We'll put the survey in the chat and we'll also send it out in an email if you need CEUs. You can go ahead and complete it. Our next session is on September 10th. We always need case presentations. So if you have a case that you would like to bring to the group and get some feedback, we'd love to hear from you. Our next session is going to be about sleep hygiene. And Dr. Lauren LaRose is going to present. Thank you, everyone, for participating, for your input, and for attending our ECHO today. Y'all have a good afternoon, and we'll see you next month.
Thank y'all.
Bye.
Thank you.